My name is Michaela Dubois. I am the community educator at Women in Transition, and we are one of the co-chairs of Shared Safety. I'm really happy to be here today moderating this Lunch and Learn, focusing on the intersection of intimate partner violence and pregnancy. This topic is especially meaningful to me as I'm currently co-leading a shared safety working group focused on creating a discrete resource card that pregnant survivors can safely access and take with them after appointments. And then Shared Safety is Philadelphia's coordinated community response to relational violence within the health and human services system. Our members include city departments and community-based organizations that work together to strengthen how we respond to and support people experiencing violence. So through these lunch and learn sessions, Shared Safety equips professionals with the resources and information they need to improve their response to people experiencing relational violence in Philadelphia. So today, as we mentioned, we'll be discussing the impact and risks of intimate partner violence during pregnancy. We hope that this conversation provides valuable information about this issue, its effects on individuals and families, and the work that health systems across Philadelphia are doing to address it. We have a few speakers today. Our speakers today are from the Pennsylvania Coalition Against Domestic Violence, PCADV, the Office of Domestic Violence Strategies, and the Philadelphia Department of Public Health's Division of Reproductive, Adolescent, and Child Health. We'll also have a Q&A at the end of the presentation. So if you have any questions during either presentations, please enter them into the Q&A box. Alrighty. So our first presenter is May Reale, the Senior Health Education Specialist at the Pennsylvania Coalition Against Domestic Violence. I'm going to hand it off to you, May, and thank you for being here with us today.
Thank you, Michaela, and thank you everyone for having me here today. I'm thrilled to be here and can't wait to interact with you all, hear your questions, and learn from you in this shared space. We can go ahead to the next slide, please. I know many of you are familiar with the Philly Four. Those are the Philadelphia domestic violence programs that are considered member programs of the Pennsylvania Coalition Against Domestic Violence. We're the recipient of Department of Human Services funds from Pennsylvania that get sort of passed through our organization to support 57 domestic violence programs that serve all 67 counties of the Commonwealth. We don't do direct service. We support those folks doing direct service, and it's such a privilege to do that work. Next slide, please. And you can find our local program. We don't have a ton of time. I want to get you to the good stuff, but if you go to pcadv.org, you can always find a program just as a heads up. And we can keep moving on to the slides. People don't have to go to a domestic violence program in their county. For example, if someone is from Philadelphia, but they're like, oh, like I'd really like to connect with a program in Chester County because I have a sister who's there, or I just feel more comfortable because, I'm thinking of moving there. Those services that those member programs provide can be provided regardless of someone's county of residence or origin or any of those things. Whenever we're talking about domestic violence, just to put us all on the same page, and this matters when we're talking about pregnancy and domestic violence. We're really talking about a pattern of really coercive behavior that's intended to get power and control over another, right? Pretty standard definition. I want to highlight when I put this definition up that this is not just about physical violence. I think we have a lot of conversations about physical violence. I think that's really important. I've been in this work for almost 15 years, and what I've learned over working with many survivors is, yep, absolutely, physical violence is a piece of it, but there are so many tactics that are coercive, especially when someone is or has been pregnant, that aren't physical, that aren't even illegal. And so people who are abusive are very in control very often of the behaviors that they're picking, and it's intentional. And so they know how to get this power without always doing things that are necessarily going to get them involved with things like the legal system or the family justice system. And they're really talented at finding those strategies. Um, I know, I don't know how many of you are ever like I came into this work many years ago thinking I understood what it was, and I certainly didn't. I thought that I was going to go to a program and I was going to work there, I was going to help people which I did, but I thought maybe like 10 people a month, right? I had no idea how many folks sought support. And so this is a stat. I don't do a lot of stats because stats for intimate partner violence are really challenging sometimes because again, there's so many different modes. But I just want to highlight that across those member domestic violence programs, on one plain old day in September of last year, 3,581 folks received services. And we can look at this number one of two ways. We can say, wow, that's a really high number. And it is a really high number. I think it's also really important to point out that the more folks that are reaching out for services and supports, the better, until we can find a way to completely eradicate intimate partner violence and domestic violence. What we want is to make sure that people are aware that they can reach out for supports. And so that's what this reflects. Next slide, please. People who are survivors have very different and nuanced needs. It's never our responsibility to tell them what they need. It's our responsibility to hear and resource them. Next slide, please. And oh, my slide disappeared, but that's okay. We'll keep it moving to the next slide. I know what it is. And what I'm going to just sort of highlight is in Pennsylvania, Philadelphia's MMRC and Pennsylvania's Maternal Mortality Review Committee are sort of rolled into one report. And I just sort of pulled out some information that's really important. You all probably know this because you're on the call, but a significant number of of the cases reviewed by MMRC have an intimate partner violence component. And we bring that up because when we look at the research, maybe something like 2% of all pregnant folks experience domestic violence. But when we're looking and we're sort of having this opportunity to really think about it, we see that that number is much higher. So I share this because intimate partner violence shows up. We can go to the next slide, please. In a way in the lives of pregnant folks that sometimes go unrecognized, and we want to find strategies to catch that and resource people beforehand. And I think we can jump 2 slides ahead now, if that's possible. But if not, also no worries, because
Sorry, guys. Technical difficulties, but
you
I'm
are
trying to
all
figure it
good.
out.
And we're at the slide that we're at is the slide that says from Pennsylvania's MMRC 2025 report. We will get there. It is not a big deal if we will land wherever we need to land. So the most common themes, these are the things that we're like, we want everyone to know how to do. We want people to know how to actually screen beyond just, are you safe at home, right? Not a great question. I have big feelings about the question. If anybody wants to talk more. More handoffs to community organizations and education on intimate partner violence and trauma-informed care for providers. Those are really the big themes and the recommendations. And that's what we're going to sort of chat through today. So this is about being collaborative. Next slide. Now that we're back, great job. I mean, I thank you so much. We want to talk about this is everybody's responsibility, and we want to be really coordinated in how we do this. So it's not, we want to make sure that domestic violence programs understand how to connect pregnant and recently pregnant survivors to healthcare. And we also want to make sure that we're clear with how do we get those folks that are healthcare connected aware, regardless of how they screen, of services that are available related to intimate partner violence. Next slide, please. And this is just the key point. Before we talk about anything else, ending a relationship is not always safe, it's not always desired, and it's not the point. The point again is how do we support folks? How do we get them some resources? Some survivors may want the relationship to end, some may not. But what I want to convey, especially in terms of pregnancy and IPV, if someone has a child with the person who abuses them, it is going to be very, very hard for that relationship to completely stop. There is going to be court processes, family court, even if eventually the person who's abusive loses custody, which doesn't happen very often, ending the relationship, being completely separate from the relationship isn't always safe, not always desired, not the goal. We want to get people where they want to be, not where we sort of anticipate is safest for them. Next slide, please. So here's what I'm really here to talk about, and I love to talk about this topic. So I'm gonna try to, uh, just share out a couple of things that we know that we see. And this is that folks who perpetrate intimate partner violence get these sort of additional coercive tactics when someone is or has recently been pregnant. They're on the next slide, so we'll put that, we'll say next slide, please. Um, and these are some of the things that happen, and these are some of the potential indicators that are linked to those coercive tactics. One of them is delayed or late or no prenatal care. People who are abusive know that this is a really good way for some stigma and some judgment to sometimes happen in healthcare environments. Um, and so again, this isn't something that's illegal. This is maybe moving someone away or not giving opportunities for transportation for care, or just simply telling someone that they don't need care. And then relying on that stigma, see, that birthing person doesn't care when they get to the hospital, right? And making it very hard to potentially ask for services or even have an appropriate kind of visit because they're coming from a space of judgment and stigma. Sometimes we see inadequate weight gain during pregnancy. People who are abusive may use those sort of physical changes to a pregnant person's body to make someone feel really self-conscious. Sometimes people who are abusive also withhold resources like food or money to buy food from people who are pregnant. They also limit other resources like access to transportation, threats to get rid of like the health insurance. Um, lack of employment, and then also things again that are sort of heavily stigmatized. They may withhold, may make it like, oh, they don't have a car seat, they don't have formula, they don't have those things that, again, when someone's asking for them or doesn't have them, our thoughts aren't always, oh, I wonder if someone's making it hard for them to get those things. Multiple pregnancies in a really short span of time. Some people who are abusive know that the more kids you have with someone, the more control you have for the longer amount of time, even if the relationship ends. And then substance use. I'm going to ask to go to the next slide, please, to talk a little more about substance use. We know that substance use and pregnancy are things that occur together sometimes. There's a million reasons for this. We could have a whole dissertation about this, and I'm thrilled to talk about it more. But in the short span of time that we have, I really want to stress that folks who are abusive may manipulate current substance use, especially with threats to contact CYS or contact law enforcement. And they also might introduce a substance as a means of power and control. And again, this is relying on some of the judgment and some of the stigma when there's a pregnant person who's using a substance. And people who are abusive don't ordinarily say, like, well, now I'm going to manipulate your current substance use, right? It comes across in a very different way. And many people who are survivors of domestic violence, because in our culture we have this sort of like it's a physical thing and we don't talk as much about the other coercive tactics. Um, Kind of commonly, sometimes people may be experiencing all of these coercive tactics and they wouldn't be screened in because it's not matching what they necessarily consider to be domestic violence. Next slide, please. We're going to skip. I just want to, we can skip to the next slide, but just as a reminder, there's lots of barriers to survivors disclosing what's happening. And it also it goes to how you ask the questions, what you notice, and what you're able to sort of pay attention to. Because again, not every survivor is going to call what's happening intimate partner violence, but they may describe those behaviors that are coercive. Um, so we always want to stress you may screen, right? Some people still say, are you safe at home? That's not an evidence-based screening tool. I'm always happy to talk about other strategies or other things, but sometimes just screening alone isn't enough. You may catch on to things that you're like, hey, I can ask some extra questions about that. You're encouraged to do so. And also, once you know someone's a survivor, you know. provide them with resources as appropriate. If someone says, I have a protective order against the father of my baby, well, screening done, right? You know that they need those resources. So once you're aware, keep resourcing folks, give them that hotline number, give them the resources, make sure that you don't just sort of force them. We're holding on until we get the right answer. Next slide, please. Whenever people um, so we encourage and sort of best practice is that everybody who works with pregnant folks normalizes conversations about intimate partner violence. We always ask in private. Sometimes that can be challenging to get privacy, but you can always reach out to me or to folks who work at one of the DV programs to sort of strategize based on your location, how you can do this. And talking to every single patient client or participant about intimate partner violence. So instead of going, oh, I think that person looks like a survivor and that person doesn't, normalize it. It's ask everybody. And then you never have to worry, right? You've already had these conversations and make it a conversation. Next slide, please. We'll skip the practicing. And I know that we all have a lot of knowledge about plans of safe care in Pennsylvania. I'm not going to read the slides to you. I will say that plans of safe care, because they can be interpreted differently by different birthing hospitals across the Commonwealth. Sometimes people may have had really dangerous experiences. Sometimes maybe people have had really positive experiences. But this is a tactic and a tool that sometimes people who are abusive will rely on when they're using that at that intersection of substance use, children and youth involvement, and intimate partner violence. Next slide, please. We'll go past the next slide, and keep inviting your local programs to the table. Next slide, please. And whenever you're doing this, it's really important that we don't just have a one-way street. People doing domestic violence work need to understand what's happening in birthing spaces, right? And people who are in birthing spaces need to understand what's happening in intimate partner violence spaces. So really that cross collaboration, so that you have a buddy that you can reach out to and be like, hey, like this is happening. What are some ideas that you have? Next slide, please. This is like if you're like that lady in the boring white room talks a lot, you're right. And this is what I want to talk about most of all. And this is if you hear no other thing, I want to stress that sharing information with all patients about intimate partner violence, this universal approach can be on discharge papers on the portal and pairing it with other needed resources like resources for substance use, mental health, sexual assault. Putting all of those together in a document everybody gets is a great way to make sure that there's a really universal approach. So we're not just relying on disclosure and we're making sure this information gets in the hands of every single person. Again, I know you guys have amazing folks at the Office of DV Programs in Philadelphia, but who talk about this. But if I can help in any way to uplift this, I'm always happy to as well. Next slide, please. And this is really my goal, right? My goal is that there's constantly warm handoffs happening. A pregnant person who's pregnant and experiencing domestic violence talks to the Philly hotline, gets services there, and then during that time they find out, oh, this person may need some substance use support. There's another warm handoff, right? We can't help each other enough. And the more we know about each other and the work we do, the more we're able to really support the communities that we serve. Next slide, please. And this is me. I am always happy to help in any way that I can. I'm deeply passionate about this work and just so sincerely grateful to you all for having me today and for the work you do in Philly. So thank you so much. And I'll turn it back over to Michaela.
Wow, thank you, May, for sharing your expertise and how we can support pregnant survivors and a glimpse into what folks might be experiencing and what we can do. So thank you for sharing that. Our second presentation today will be led by Azucena Ugarte, the Director of the Office of Domestic Violence Strategies, and Asta Mehta, the Director of the Division of Reproductive, Adolescent, and Child Health of the Department of Public Health. Thank you both for being here today, and I will turn it over to y'all, Asta and Azucena.
Thank you so much, Michaela. And I'm going to get us started and pass it over to Azu. And thank you, May, for such a great presentation and nice overview of all of the work and sort of the reason why we're here today. Really appreciated you setting the stage. So our goal today, we can go to the next slide. Our goal today is to really share some of the more concrete on-the-ground work that we've done around this intersection of intimate partner violence and pregnancy here in Philadelphia, and really sort of provide sort of how we kind of went about that and sort of some of the outcomes of what we've been able to accomplish. And so Azu and I have been working together for many years on the Philadelphia Maternal Mortality Review Committee, and through kind of reviewing these deaths and sort of seeing the intersection between maternal mortality and IPV, we really wanted to better enhance the systems on the ground to identify IPV in pregnancy, and then concurrently be able to enhance the warm handoff that happens around that, and really sort of overall increase on the ground providers on how to best ask those questions and how to best then provide resources when survivors are ready. And so we went through this in like sort of a stepwise fashion. Some of it was sort of in parallel, but I'm going to talk you through our establishment of our multidisciplinary team. We then were able to work on a standardized IPV screening, which we'll talk about, and our framework was really focused on the delivery hospitals in Philadelphia. There are 5 of them, and we really kind of wanted to start there as like the sort of point of care of where we can identify more, feasibly with like a sort of small number, not small, but like a small number of hospitals versus like a large number of community providers, which becomes a little bit harder to implement quality improvement projects. And then we were able to then develop a training for these providers in response to the multidisciplinary team, and then created a public health campaign again to call attention to the issue, and then develop the warm handoff. And we'll walk through the details of each of these steps. So go to the next slide. So first and foremost, we wanted to be sure that we were doing this work in partnership with all the stakeholders, or all the interest holders that needed to be at the table, that were going to then carry on the mantle once we sort of brought them together. And so we, as REACH and the Office of Domestic Violence Strategy, served as the backbone and like sort of the convening organization to bring all of the interest holders to the table. And so you can see here, we had folks with lived experience, first and foremost, that were part of this team. All of the health systems were represented in the city. All of the DV and sexual assault agencies were represented. We also had researchers who were really like our partners in the evaluation of the project as part of the work. And then of course we were there as the backbone and the government. So we convened all of these folks together to really, again, figure out how to tackle this issue of QI in hospitals, but also in partnership doing the work of the warm handoff. And that's why it was so important to first bring folks together to build that trust and really hear from them as to where they're seeing gaps, and then figuring out how to address those gaps in a way that was measurable and that we could demonstrate impact. We'll go to the next slide. So this is a list of all the delivery hospitals in Philadelphia. Like I said, there are 5 of them, but really 3 health systems are represented here, Penn, Temple, and Jefferson. And so while there's only 3 health systems, it is a big lift, even though to be able to implement any kind of QI work within those institutions. But the goal was, again, to embark on universal screening for IPV in the institutions, and then capacity build for them to be able to respond to that and then be able to refer to resources. So we'll go to the next slide. And so first and foremost, we wanted to be sure that so I guess I should say that was one part of it, was convening all of these institutions. The other part was better data collection on the back end, in terms of the sort of relationship between IPV and maternal mortality. And with that, we were actually able to approach all of the DV agencies. So to give you a background of how we review deaths, in Philadelphia, is really dependent on what information that we receive from our partner agencies, and so what the story is behind like the circumstances surrounding the person's death. And for many years, the Philadelphia MMRC has been convened for 16 years now, but for many years we weren't consistently receiving information from the DV agencies in terms of like if that person that died had an interaction with the DV agency. And as you all probably know, IPV is so underdiagnosed in medical records and things like that. So hard to gauge like whether or not there really was a connection. We know it's probably underreported. And so we were able to work with the DV agencies to develop a system for them to send information to us if we are reviewing someone that died, so we can know more robustly, kind of what were the circumstances surrounding that person's life. Was IPV a part of their, their story? And so we were able to do that. Oh, sorry, I'm speaking too fast. Okay. So we were able to, I will slow down. Sorry about that. So we were able to work with these DV agencies to get more streamlined records. And that actually happened within one meeting. And so it was really kind of amazing that after all these years of not receiving any standard information, just by kind of convening folks, we were able to operationalize that in terms of our MMR data. And the next slide. And then, like I said, like the more implementation of the work around like sort of like a public health or a quality improvement was to implement universal screening at point of care in OB triage at the delivery hospitals. And so we developed implementation guides for hospitals to be able to, kind of give a roadmap for how to implement this universal screening. We were able to share some of the best practices for screening tools for IPV and pregnancy. That's all in the implementation guide. And then we worked with institutions to put all of this information in their EMR. And then we also developed some, education, which Azu will talk about, to help arm the actual frontline staff on how to best ask these questions. And so, in terms of the guide, the input was really important to get from lived experience experts about what they have encountered in these settings. And we wanted to be sure that in implementation of a QI project that we were being responsive to what they were noticing as gaps. So we were like sort of addressing that in best practices. And we'll go to the next slide. And so, am I doing this, Azu, or are you? I think this is you now, right?
Yeah, I can do it.
Okay, great. Okay.
Just waiting for the handoff, for the warm handoff.
The warm handoff.
Yes. Thank you, Asta, and thank you, May. And hello, everyone. I'm Azucena Ugarte. I'm the director of the Office of Domestic Violence Strategies. So I'm going to follow up with the project that we had here in Philadelphia. It is the 5th year of this project. And as Asta mentioned, there are two components. It's to work with the delivery hospitals to improve the way they were screening for IPV and the response, and the other one, the data piece. As already mentioned, the screening piece, something that I just would like to add about that. We actually had a training for the implementation team about IPV, about pregnancy, about screening, and it was great to have representatives from the hospitals there, lived experience experts, the domestic violence agencies, everybody receiving the same information and being at the same page about IPV screening and pregnancy in delivery hospitals. And the staff from the delivery hospitals, I think since the beginning, they were very clear that they understand this is a problem and they want to do something about it, that they see it, and that they needed the tools, and they needed tools to do the screening. They were already some places doing screening, but doing only 2 questions, only 1 question, or they were not reviewing, etc. And on the other hand, one of the main things was, it's not about the questions only. We need to know about the topic. We need to know how to respond when there's disclosure, or when there is not disclosure, but we suspect something is happening. And then the other thing, and we'll get there, is, and then what? I can ask the questions, I can try to do in a very trauma-informed way. And when the person responds, yes, this is happening to me and I need help now, then what? And that's the piece that May mentioned about warm handoff referral. But about the training, with the implementation team, because training was identified as a need, we went over different topics and modules. So the implementation team identified that we needed 5 different modules, included the topics, and then we subcontracted one of the domestic violence agencies here in Philadelphia, Lutheran Settlement House, that has been working with children's hospitals mostly about these issues. So they created the content for the modules, and then the implementation team reviewed the content of the modules, provided feedback, and then it was live. As of now, at least 646 OB triage staff have been trained across the 5 delivery hospitals. We have 1,060 pre and post service that has been collected. And we have our evaluator, Child Policy Lab, who is also contacting people 6 months after to see if there's knowledge retention, and there's an average of 89% of retention. These are some, you can go to the next one. Yeah. These are some of the, you can click again, I think there, yeah. This is a couple of quotes also from surveys or interviews that CHOP has had with people about the training. It felt the training was good and in touch on these issues. Like, you have to kind of meet patients where they are and let them know that there is help there, but also understand like where they are coming from and how they feel, and not to force them into, giving information, doing things that they don't feel comfortable with. This is a registered nurse after receiving the training, and this is something for us domestic violence advocates. It's a key thing, right? You're not screening just because you want to know, and you don't want to force disclosure if the person doesn't want to disclose at that moment. There are many reasons why the person may not want to disclose, but you are screening because you want to connect the person for services, and the person says no, then we need to respect that and then keep working with the care that we can provide. And another quote from the training, I did find it really helpful that they were role-playing, because screening is probably the biggest challenge for people. So these are really positive comments about the training. We can go to the next one. Another thing that we did at some point during this project is create a citywide public awareness campaign about IPV during pregnancy. We had 2 target audiences. One was the public in general, and the other one was medical providers. The main message was that moment that you have in your personal life for the general public, the one moment that you have with this either friend or family member who is pregnant, that one-on-one moment that you have, and you have different images there, the one moment that you are riding the car together or going for a walk together or going shopping together, that may be the one safe space that survivor has to tell you what really happened. And that what you could do is ask, express concern if you are concerned, and then offer to connect them with resources. Similar in the case of the healthcare providers, the one visit, that maybe that prenatal visit, it may be the one space that actually this patient doesn't have the controlling, abusive partner right next to them. And it could be the space that then the provider can use to ask those questions, screen, and try to provide services if the person wants to. These are some numbers from the campaign. We reached 186,000 people. Around 200,000 Philadelphia women saw the campaign in their feeds, an average of 5.5 times. There was over 1 million ad impressions, which is pretty impressive when I'm used to have like small campaigns that we do with DV that we make them on in-house and reach hundreds of people. So see something that is like thousands of people. It's really impressive. And we learned also some things from this campaign that, for example, people tend to click more in ads that present images of people that look like them, which is it's kind of common sense, but it's also good to see like, okay, we actually have the data about that. And there was also higher click of people that were speaking Spanish in certain areas of the city also. So it was good information also for us. We can go to the next one. Then the other piece I was mentioning was the warm handoff. Something that, as I said, kept coming up is what do we do with a patient survivor that needs help immediately? And hospitals, they provide services 24/7. The domestic violence organizations don't provide services 24/7, except the domestic violence hotline. So something that came up from there is that we needed to enhance the domestic violence hotline to be able to receive more calls from the hospitals and be able to support survivors. But the other thing that came up is that even if we provided the hotline right now, if the person needs support immediate, like the person says in that moment, what I need is a cell phone, a new cell phone that my ex-partner is not going to track. What I need is a bus ticket to go to my brother's. What I need is spend the night in a hotel because the two domestic violence shelters in Philadelphia are full. That the hospitals needed to be able to somehow provide that. And that's what we created the Philly Safe Fund. That is this like concrete good fund. It's immediate. It's very short term. So it's like, okay, for the next 24 hours, 48 hours, this is what we can provide while this patient survivor connects with the Philadelphia Domestic Violence Hotline or specific domestic violence agencies or other resources that exist in the community. It is a pilot. We are capturing data about that. These are some of the quotes from the workers that have referred people. If we can get a patient into a shelter through the hotline or the resources, the Concrete Good Fund helps provide immediate assistance, which is much better than just completing a safety screen and hoping for the best. This is from a social worker from a hospital. She was so thrilled. She was so relieved. And she was grateful that her daughter could go with her to the hotel. That was very reassuring for her. So that was awesome. That's a registered nurse also that did a referral. We keep evaluating and looking for ways that we keep tweaking the process and see what we can do to sustain it. The other piece that I want to mention was enhancing this domestic violence hotline. What has been done about that? There was a whole process, a year process of assessing the domestic violence hotline and identify how we can improve it. There was a process in which the domestic violence agencies led the process. Women Against Abuse is the one that manage and operate the hotline with the other 3 domestic violence agencies. So they had a consultant that interviewed survivors, interviewed the hotline staff, interviewed the domestic violence agencies, held stakeholder focus groups, have also one-on-one interviews with other people, look at the hotline workflows, the pain point, studied peer models from other cities, drafted recommendations. And one of the big things that came up is that we needed better technology, that the hotline was using the technology from 2005. So we were able to invest on that. And now we are having a hotline that once all the technology and those all mechanisms are implemented, it's going to improve of our response. It's going to be more timely, compassionate support, and we're able to get more referrals from the hospitals and support survivors that are coming from the hospitals. I would like to add that we also did a training for the hotline workers who answering the calls about this project and about the concrete goods referrals. I know, May, you were part of those trainings too. So, okay, the next one. So key outcomes, I mentioned some of them already throughout the presentation, that so far we have 646 OB triage and perinatal staff trained across the 5 hospitals, over 1,000 people finished pre and post test. All the delivery hospitals selected a validated IPV screener, and they included a screen into the emergency medical record, so it's part of their workflow and the process. 100% of data request responses from the domestic violence agencies. As Asta mentioned, now every time we're reviewing maternal mortality cases, we can say, yes, this person actually received services from a domestic violence agencies, or no, we have no records that this person ever received domestic violence services in Philadelphia. The Philly Safe Fund launched at the 5 hospitals, and the evaluation is ongoing. We have some results, but it still keep happening. And the next one, please. So we have learned some lessons. One of the 2 first things that was very clear for us, having a multidisciplinary implementation team has been crucial. So hearing from the hospitals, hearing from the domestic violence agencies, hearing from researchers, and I think for us especially, hearing from lived experience experts has been key for this work. Coordinating through local government has helped with stability and accountability. There was a lot of work in the implementation team, and then a lot of follow-up that happened with each of the community stakeholders. Improving the hospital's response, and this is, I think, in general, improving the hospital's response to intimate partner violence require increasing the capacity of domestic violence services. And I think that's something that we need to think. As systems, sometimes we think like, oh, we can get better, any system, about identifying intimate partner violence, and then we just send them to the domestic violence agencies and they will take care of it, right? Like that's the response. And domestic violence agencies do a lot of work with few resources. So it's important that we work together to figure out, as May say, what is this warm handoff referral is going to happen? What is the capacity of the domestic violence agencies to receive survivors, do the referral? What is the time that they have to actually respond to this type of situations? And what then we can build in both ways. We cannot expect that, the domestic violence agencies would figure out the housing, the legal thing, the children, everything, because the resources are limited. And then the other thing is sustainability is key. If you're doing a project like this, think of sustainability since the beginning, not in the last 2 months of the project. Workflow integration is more sustainable than a standalone initiative. So having, for example, the workflow for a screening and the actual screening to integrate it into the practices of each hospital, integrated into the electronic medical records, ensures that the screening practices are going to continue even until after the project ends. The other thing that we are doing, for example, is the online learning modules are going to be transferred from where we have them right now into each hospital learning management system, so the education can continue there. Leadership engagement is critical for long-term adoption. Evaluation data strengthens hospitals buy-in. This is also very important. Hospitals and certain systems pay more attention to data than other systems. So when you're working to improve systems, think about, is this a system that is going to respond better if we talk about cases, or are they going to respond better if we show them numbers, or a combination of both? And then flexibility across hospital system is essential. Each hospital has their own culture, their own workflow. They were going through different things, their own hierarchy. So working with each of them to understand and to support them, it's also important. And I think that was my last slide, and we have time for questions and answers. I don't know if Asta, if you want to add anything. Okay, Michaela, then it's back to you.
Thank you so much. It's always so wonderful to hear about what Philadelphia is doing to address not only IPV and pregnancy, but maternal mortality. So thank you both for outlining that work. In terms of the Q&A, I see we do have some questions. Let's see here. I'm going to start with one. So the question was, how can you safely follow up with patients throughout the process? So, you know, I guess to make it more specific, how can you safely follow up with patients or a safety plan throughout the process of pregnancy and postpartum? That's how I would interpret that. Do any folks want to answer that or feel strongly about answering that?
May, do you want to go first?
I think just in terms of like, so following up, like it's when it comes to programs, we're never going to be able to like confirm that like follow up. I think that you can also just be very aware that like programs are always going to try to follow up. And when people are in touch with a domestic violence program, there's safety planning happening, right? So, like, if somebody calls the hotline right now, this moment, they're going to get those resources that they need. They're also going to like talk about safety and understand that, like, they can call anytime. And sometimes that sense of like the programs aren't necessarily going to be able to close the loop in a healthcare space or in a community space can feel frustrating. It's just it's the way that it is for a million protect survivors and also give them some of that autonomy. So, but also I think if you have questions about follow-up and you're in communication with a patient or a client, ask them. And sometimes just being able to like, I know like sometimes when I call for supports or services in an environment, I may not have asked in the way that like another person would. So sometimes just that dialogue with a trusted healthcare provider or caseworker or therapist can be very helpful.
Yeah, I agree, May, and I think this is something important to know for the hospital systems or other systems that refer patients or clients to the domestic violence agencies. The domestic violence services are completely confidential. So some systems sometimes want to call back to the domestic violence agencies with very good intentions, like, did my patient make it, pretty much? And it could be very frustrating when the domestic violence agency responds, sorry, we cannot confirm nor deny that information. If the patient was to contact you, they would, but we can't. And I think the other thing I want to highlight, what May said also, you can follow up with them in your next appointment, right? And you can you can ask the patient, is it okay if the next time you come, we follow up on this? Or would it be okay if I ask you the same question before? Or if this is a program that also call back patients to follow up around appointments, what is the safe number to call you back? And what is safe for me to write here? If you come with a family member that is not your partner, is it safe for me to ask you about these questions in front of them? Probably not. But if you are not sure, ask the patient and follow the patient as much as you can about how to support them. Yeah, follow their lead.
Thank you so much. We have another question from a participant about kind of balancing grief and health and safety. So I'm going to read that question. The person shared, and they work at a nonprofit of domestic violence prevention. And she shared that during a recent miscarriage case, she noticed that the interview's focus was predominantly centered on investigating whether the father had been violent, placing the mother's containment and her state during the loss in the background. So her question is, understanding that detecting violence is vital, how can we balance the protocol to prioritize a mother's grief and health in that critical moment without neglecting safety? A big one, but about balancing different parts of the process in this particular case. So, May, I know you responded to that. I don't know if you had something that you wanted to.
I You actually answered, Michaela, because I was curious, like, what was the context that this person was in? And for me, I think this just sounds a lot like being like deeply trauma informed, right? And so that balance it's not that you necessarily have to pick this or that. It's really about trying to like if it's part of your role to figure out like information, being like clear about like, well, I'm gonna ask you some questions because I have to or I need to in order to be able to help, and also know what you have to ask and what you don't. I think like if someone tells me they're a survivor, I'm like, okay, you're a survivor. I don't need to know the details beyond that. And if you also are, like, this is where I think a lot of that beautiful warm handoff can happen. Like, maybe there's, a doula who does grief work, right? That this would be this really beautiful opportunity to say like, wow, so much is happening and I can help with this. And then my colleague can help with this. So that it doesn't have to feel like all of the person's needs are in competition, but are able to be held all at once without one person feeling like they have to have every answer.
Thank you so much. One more question, I think, looking at time, but I think it was an important one. And specifically for Asta and Azucena, where do you see the greatest opportunity for innovation in supporting pregnant people experiencing IPV or protocol development, that kind of field as well?
I don't know if I think there's this is a place for innovation. This feels more like a place of systems coordination. So I guess like if there's innovative ways to do that, recognizing that there is like legal barriers around like confidentiality and safety that we all, have to like navigate through. So if there are creative ways to navigate those like existing kind of barriers, I can see there being that's where the innovation I think is like that we're still kind of working collectively, all of these different systems to be able to support a survivor as they're, journeying through pregnancy and postpartum and beyond. So and in terms of like concretely where I think there needs to be more systems enhancement is, well, while our project focused on the inpatient setting, certainly expanding that type of quality improvement to outpatient providers as well. And then concurrently being able to build out the warm handoff and the support. Because if you ask more questions, you're going to potentially identify more folks that are experiencing this. And then what do you do with that information? It's that same conundrum, anywhere. So you can't truly build out any type of screening without thinking about what happens after the positive screen. So I still think that there's a lot more systems coordination that needs to be done. As we mentioned, the hotline and the enhancements there. And I think there's like that, will, I think, go a long way in helping sort of coordinate a little bit more with like, the different settings where IPV is identified. But I would say that's my like big picture thought around this.
That is a great answer, right? Building on what we already do and what we've already seen as successful, and then branching that out into different spaces. Thank you so much for that. I recognize that we're at 12:57, so I'm going to start wrap up. So here are some of the resources that were mentioned from today in presentations. And thank you so much to our incredible speakers for being here and adding your expertise and sharing the work that we're doing. And to all of our audience members for coming and engaging and asking your questions and also doing this work in such a really important subject. So just some housekeeping. We will send up a follow-up email to folks who signed up for this panel today that will include these resources. And if you submitted a question that wasn't answered, we will answer that in that follow-up email. So, and then, yeah, thank you to our speakers again, Maya, Susanna, and Asta, for sharing your time and expertise. And thank you everyone for coming today. Have a great rest of your week.
Thank you, everyone.
Thanks, everyone.